All right, I think we're slowly getting there. So let's see. Okay, welcome everybody to today's live stream. Let me just I have too many machines now working at the same time. Yeah, welcome. This is the live Q&A session of 8th of April, and today we're going to focus on the MRI, and this is kind of like a Q&A session, so it's kind of like a mix between a live session on Google Meet. So you can see if you want to actually join the call, you can go here on school/MSK-RAD, so you can see the link also on your screen. You can register there for free. There is a calendar, I'll show you this. So if you register, you land on this page. There is a live button here. You click here, you join the Google Meet link, and we can see there is one person already in the call. Typically, there are not many people on these calls in the free community anyways, but I just want to, first of all, make sure we have everything settled. So in the chat, can you hear me? Can somebody confirm that the audio is good? Let me just test myself. Oh yes, I can hear on my laptop. I think that's good. Okay, very good. So what I want to do is use this today, Iman, as a little test for the Olympics also, just to make sure the setup is correct. And I know you have no microphone, but so if you have any questions, you can pop them in here. But before we do that, the next thing I want to do is basically try a new tool today for the lecture. Well, it's not really a proper lecture, but it's an interactive way that I'm trying to explore and see if I can use this for the teaching. And I'm gonna start this presentation now. Let's see if this works. Maybe I need to make this full screen. Let me just go back. I think, oh yes, I need to start this again. Let me just load it up. Let's go from the start. Okay, so this is called RapMet. This is a new tool here with integrated presentation and quizzes. So we want to make also use of some lovely quiz function that I want to try out today. And let me start this here. So if you have your phone ready or even on the computer, you can join the actual session here. If I go present, don't care about this. So I'm going to start here. So you can now scan this QR code, or you just go to rapmet.net and enter this code. So I'm giving you a minute or so to sign into this. I'll do this also on my laptop because I want to see how this looks like. Obviously I had a demo, but if you want to scan the QR code, you can do this, or you just go in with your computer regularly. I'm just gonna do it like this so you can actually scan it. I'll do this on my own, on my end. RapMet. And then we will have one or two slides and a lovely knee case where I have a little quiz for you guys. Yeah, and as I said, this is basically a test for me to get used to the software and tools for the MSK Olympics, which will be held in over 6 weeks or so. So I'm gonna, oh yes, I don't even have to register. I can just join as a participant in RapMet. That's amazing. RapMet, no need to register. I just type in 1CVR3. Let's see. Okay. Very good. Let's see if somebody joins. Okay. Imane, are you in the call? Wait. Oh, yes. So I understand. You can't see anything because I haven't shared my screen. Let me just do that. Because you are in the actual call, so you're not watching the actual You're not watching the actual stream. Okay. So you should now see the QR codes. You can scan this, or you can just use this one here, Iman. So I think this would be better. Just type in RubMedNet and then enter this code. And you should then see a screen that says untitled case list with 2 slides and an MRI that I will show you. So I'm giving you a few more seconds. And we've got only like 6 viewers on the chat, on the YouTube stream. That's fine. I didn't announce this in advance because basically this is just a technical test with a lovely knee case, so I'm sure you will learn something, but bear with me if there are some technical difficulties. So I think you are in now. If you didn't manage, then let me know, Iman. You can also see the code up here in the upper right corner in case you are late. So this is now the case. I'm taking this to my other screen so I can see what's going on in the chat, and then we can make this big. I can make this even full screen, I think. Yes, so this is much nicer. Okay, very nice. So we want to focus on the MRI today, and first of all I want you to have the option to ask me questions. If you want to ask me, come to the live Q&A session. And Iman, do you have a... Oh yes, so another person is joining, so I'll let them join here. Hi Gotze. So you joined the live call. If you want to know, type in the YouTube chat. If you don't know the link, I can actually just copy the link in here as well for you. AVV School MSK Red, register free, join Google Meet. Okay, so if you want to join the Google Meet, or you can just also log in here on rubmed.net. So let's go straight to the case. I want to see if this works. I think on your end, you should now also be able to scroll actually through the case. So you can just drop this in here. You can see this is a proper DICOM viewer. We can also change the layout. We can have 2 by 2. I think that's nice always. And I see my camera is a bit too big, so I'm gonna move me a little bit to the side. Not that important. All right, so maybe like this. Okay, maybe the chat is also a little bit in the way, so let's move the chat also a bit to the side, maybe down here, because actually you need to be able to see this. Okay, so have a look at the case, and then your task now is to click on the pathology. So you can click somewhere. I'm trying this on my laptop too. You basically have the annotation task, where is the pathology, and focus on the most important pathology, because there's obviously more than one thing going on. So you just click on annotate, and then you draw a box which covers the pathology. Now obviously you want to make that box as small as possible, otherwise you might actually be out of the gold standard. And you can do this on any slice. So if you see some edema here, you can draw the box in here, you can draw it on the meniscus, you can draw it somewhere, you can also go to the second plane, etc. And then I'll give you a minute or so to actually go through the case. I can also then go with you to the whole case together, and then we have a look at the answers. Okay, so still checking the chat, that's good. Chat is very quiet. Okay. So yeah, I think technically you should hear me and everything seems to work. So I think that's gonna be great for the Olympics actually. Amazing. The camera is also working. That's always also a good sign. Okay. So I'll give you a few more seconds here. Scroll through the case. I hope you have a search pattern, so I'm just going then, after we show the findings, with my proper search approach through the whole case. We can also change the layout to 4 by 4, but I think for the streaming purposes this is now too narrow. I want to keep it 2 by 2 or 2 by 1 rather. And here you can, I think you might even go through the slides yourself. Okay. Once you are ready, or if you join late, you can always, we just type this also in the chat because some people are joining only now. the presentation here, robmet.net, and enter code 1Z WR3. R3. Okay, so I see 4 people are in this call now. This is how you can join with the mobile phone or tablet or whatever, or you just type it in and go here. You can also just easily, no, you cannot copy that. So maybe they should make this field copy all and then type this in. Okay. Okay, so I think that's enough time now. If you have nothing to do while I go through and you already know everything, then you can also, like I popped in the YouTube chat, join the actual call. We can see we are in this actual call where you can also just use the microphone or webcam, and we have a little discussion after this. Okay, so let's see what the group answered. I'm gonna try to find if I can actually see the answers. Doesn't look like there are any answers. So somebody made a nice drawing here, so that's good. We see something here. Let's see if we can see something on the T1. No. On the sagittal, this is the same person, so maybe only one person so far has entered something. Not here, not here. Okay, anyway, so I want to show now the presenter answer. I have also on this particular image this box. The green one is mine, so we can take this off. Basically, we see the edema. I have a second one here on this image, and I have also another box here. You can see here where we've got a meniscal tear. So yeah, the idea here is really that you can have these heat maps of where people click and see the pathology. Now, obviously for MRI, this is a bit more tricky. Maybe I should just focus on one series rather than multiple series. So this is something for me now to identify, and I want to make use of this tool for future live streams, which I think will be great. So bear with me. Again, this is just maybe a technical test. But anyways, so let me go through the whole case and take these 2 answers away. So when I go through the knee case, I just want to repeat the search pattern, because I think this is one of the most crucial things. You need to have a proper search pattern, and for knee MRI, I always start on the medial side. And this is whatever the question is on the knee, except maybe for a tumor case, I start on the medial side. And on the medial side, there basically I'll always start off with the meniscus, because this is probably the structure that the surgeon most commonly is interested in. So we want to have a look at the meniscus now here. On coronal, we can see there's some cystic change here at the anterior root attachment. It's not very important, so we go back here. There's anterior root is fine. Then when we reach here the body and to transition to the posterior horn, we start to see a horizontal line back here in the body. It has contact to the undersurface. When we go to the body itself, it becomes quite irregular at this location. And then this is probably one of the major findings in this case. We can see there is a small undersurface tear, like a little flap from the undersurface that flipped over the medial edge of the medial tibial plateau, and it's hanging here into the meniscotibial gutter. This is quite a common way of small tears, and they can easily be missed. They can happen at the posterior medial corner, they can happen here. This is typically the 2 locations where you see them, and they can be very easy to miss if you just scroll through or if you have like bad image quality. As you can see, it's not much to see on the T1, but they are quite important because they obviously, these flaps are bothering the patient and they can cause pain symptoms, and most often you also see some irritation and inflammation of the adjacent joint capsule and ligamentous structure, meaning the meniscocapsular attachments, MCL, a deep MCL also, and the joint capsule itself, which is also the case here where we have some edema here in this non-traumatic case. And in addition, so this is one of the findings here on the medial side. We obviously want to verify this on the second plane. We see the cystic change, anterior horn, otherwise is good. We go over here. We can see the horizontal tear in the posterior horn of the meniscus, some fraying of the root and tip of the posterior horn and posterior root here. We come now more to the body here, and then this transition we can see the irritation of the meniscocapsular attachment, and then here we don't see the flap on the sagittal due to partial volume averaging. Sometimes you can also see them on the axial actually, where they just pop over the edge, and I think this is actually part of this tiny flap that we can see here. Okay, the next thing we want to look at is the cartilage. So we can see the cartilage is on the tibial side, it's nice. There are no focal defects. On the femoral side, we immediately see there is quite a large bone marrow edema. In terms of the cartilage, there's some thickening and irregularity of the subchondral plate over the meniscus here, and this is most consistent with a subchondral fracture. In this elder or older patient, a subchondral insufficiency fracture. Most likely we can also check on the T1 if we see some form of a line. There's just a bit too much irregularity to just think about a bony stress reaction or something, so I would actually give a tiny microtrabecular infraction, although the term that has been recommended recently is to just call them subchondral fractures. So it's a small one here, maybe it's in a subacute stage, with the edema being only limited here, because with the classical subchondral insufficiency fractures, the edema are typically covering the whole femoral condyle. So here it's kind of like a borderline situation. Maybe there is some overlaying cartilage fissure and it's just reactive, but I think there's some microtrabecular fractions going on. And anyways, it's, you know, there's a continuum between bony stress reactions, trabecular collapse, fracture, and so on. So we need to find a term where we are comfortable with. And I think in this case here, I don't remember the exact age, but I think that's probably a female, 50 something. I think I would make this a subchondral fracture, and given the fact she is it's not very extensive, maybe in a subacute stage. Okay, so that's for the bone. Then we check MCL, which is continuous. We can see the superficial portion here, the deep portion. Also, there's some periligamentous inflammation, especially here in the posterior border of the MCL, which is consistent with some focal inflammation. That's okay. And then we go to the axials, and we're going to check for the Baker cyst next, and we check for the pes anserine tendons, which are unremarkable. Okay, so this is basically everything on the medial side, and we can go straight to the lateral side. On the lateral side, we do this again, the same. We look for the meniscus. We need both planes. On the lateral compartment, basically everything you can see on the coronal view, except a few small details, but typically you get a good idea of what's going on here. There may be some signal change back there. We check on the sagittal here, but there's no obvious tear. We see some osteophytes, cartilage is fine, no bone marrow edema. We see some tendinosis of the popliteus tendon. Proximal tibiofibular joint is okay. Lateral collateral ligament or fibular collateral ligament is unremarkable. Iliotibial band is also fine. So we can check on the sagittal here, and basically just for the meniscus, and for the cartilage. So we're going to here, we see not much, maybe some irregularity here, some fraying of the posterior root, but no obvious tear. Fovella is okay, and we also check this area here for the cartilage defects, because that's not visible or not easy to see on the coronal. And lastly, we can also briefly still check on the axials, just to make sure we have a thorough view and we don't miss anything, especially also the common peroneal nerve and the tibial nerve here, where I don't see anything that jumps our eye. Okay, so this is for the lateral side. Then the next thing is the coronal view for the intercondylar compartment, and here we want to have a look at the ACL. So we see down, ACL coming down, that's fine. We see the PCL also, both look fine. I wouldn't make much out of this here. I think that's okay. And then we go to the patellofemoral joint. Just checking what's up here. The intricacies of live streams. Okay, good. Then for the patellofemoral joint, we mainly use the axials and sagittals, and we can see there is large, deep cartilage defects here on the retropatellar surface, all the way down to the bone, with some little bone marrow edema, and also some irregularity of the cartilage of the trochlea femoris, with some deep fissure in the groove here. And you can also see this on the sagittal here. The signal is abnormal. We've got some low signal areas, which is consistent with fissure or just chondromalacia and degeneration. But it's kind of like a mix. So we have like this advanced patellofemoral osteoarthritis, or mainly retropatellar osteoarthritis here. Not a lot of, well, no effusion. And we have, what's this? Ah, yes, somebody subscribed. I was kind of like, it's too loud for my headset. Sorry, I startled a little bit. Okay, let me just double check. I don't know which direction is actually making this less loud. So I do it here. Otherwise I get ear damage. Yeah, thanks for the subscribe there. So I was about to say that there is no joint effusion, so this is just normal limits, and we see the extensor tendons are coming down, that's fine, quadriceps tendon, we see the patellar tendon, we see a Hoffa-Fett pad here, and in the Hoffa-Fett pad there is some subtle edema here between the patellar tendon and the lateral femoral condyle. but we don't have a patella alta situation. If we look at this and just from eyeballing, this is less than 1.5. I can't measure on this tool, can I? No, I can just zoom, window, scroll, pan, and layout, so I cannot really measure something, but that's okay. And then we see some non-specific subcutaneous edema over the patella and patellar tendon. This is very, very common. You see this in so many people. This can be people who kneel occasionally. It can be just random, more like adipose people, but this is hardly ever associated with really symptoms unless you have a proper fluid collection, as in a prepatellar bursitis or infrapatellar superficial bursitis or something like that. So in this case, we can describe this in the description, but we don't really mention this anymore later down the road in the conclusion. So yeah, this is really this case. We have these three major findings, I would say. So the most obvious one would be the small meniscal flap tear on the surface into the meniscotibial gutter here at the body of the medial meniscus, and then these subchondral fracture or insufficiency fracture here with moderate edema, less than we would expect in a proper insufficiency fracture. So it's kind of like this borderline between stress reaction, maybe from the meniscal tear, and some atypical, stress on this area. But given the fact we see this thickening here, maybe I can make this bigger, of this thickening of the subchondral plate here at this location, I would give still a subchondral fracture or infraction. Like in German, I separate this, even if in the English literature it's not the recommended term, but I think subchondral trabecular infraction or microtrabecular fracture or something like this tunes it down a little bit, I think, and makes it less sound severe. And I would probably add most likely subacute because we don't have this extensive edema. So 1 and 2 finding, and then I would mention also there is adjacent meniscocapsular ligamentous irritation, which is quite common. And then the last one would be, well, 2 more, the patellofemoral osteoarthritis, but it doesn't look very inflamed at this point. Maybe some edema here, but there's no effusion, no obvious synovitis, and then maybe some very subtle suprapatellar Hoffa edema, which is patellar tendon, lateral femoral condyle friction syndrome, or can be consistent with that, and they can clinically correlate this. This is not the most beautiful case, but I think it's a bit more than we would expect normally. Okay, so this is basically the case in a nutshell. And now, because this is this super great tool, we can just go here to the next question for you guys. Okay, so, and you can see now on your screen also multiple choice question. Your question for you is now, is this a surgical case? And you have to answer yes or no. And I think I just realized I need some sound box or something, like a little quiz music or something in the background. I definitely need to get this. So Boba T is having in the chat, what is yak? You are yak, but read backwards. So I don't know what that means, so maybe rewrite this so I can understand. I don't understand what you mean. Okay, so answer the question, and I'll give you 10 more seconds because it's just a yes or no, or basically it's a yes or no answer or question. 2 answers we have already. I can see that here on my screen. And let me just double check if you can actually also see that. Surgical case. No, you cannot see how many people are answering. You can also not see how many are in the call, which I think is interesting. Okay. So yeah, maybe we get 3 answers and then we have a way to decide. Well, I can actually also answer myself on my laptop. And so I'm gonna, okay. Let's see, we still have, yeah, we have 5 answers now. I think that's fine. Great. So let's see the presenter answer. No, let's see the group answer. Okay, it's both in one. Okay, so we can see most of you think it's a surgical case, and I agree, mainly because of the meniscus, because of the meniscal tear, which would be the surgical thing to debride or just make this flap go away. And then we wouldn't do much about this one. The cartilage is fine. There's no need for any intervention. And also for the Hoffa fat pad impingement, there's no need for any intervention. Okay, very nice. So this is basically the 2 things I wanted to talk about. And these microflap tears that I just showed you here are easily missed. So always really look out for those. this can really be something that the surgeon needs to know, because it explains the symptoms very well, even if the remainder of the meniscus looks quite normal, or even like if you look at this horizontal tear that by itself would maybe not qualify for a partial meniscectomy because of the degenerative nature. Well, they might still take away a few of these other bits here, but these small tears are important because if we maybe, let's say we don't have this additional horizontal tear and you just say meniscal degeneration and or the surgeon wants to go in, it might be a bit difficult for the surgeon to actually, for a surgeon to justify arthroscopy, because the MRI report didn't give him a proper target, and he will be in a conflict with insurance potentially and has to justify why he actually did the surgery. And then he will be a little bit mad at you because you didn't describe the meniscal tear that he maybe even saw himself, or she. So it's always good to be here on the side of the surgeon, describe these little tears and make the surgeon happy, because then he knows, okay, he has the justification to actually go in and help the patient. That's really something you need to look out for, small microflaps here. And sometimes they can be tricky, and I showed you already one of the tricks to get around is sometimes the axials, when you can see how some of the meniscus substance on the next slice, where you should have only the tibial plateau bone here, and then they reach a little bit more down here. Obviously we don't want to mix this up with the deep MCL layer or something like that, so we need to have this correlation on the other planes, but sometimes you can really see these flaps here and you can measure them, you can give them a length. And even sometimes on the sagittal, like if they are big enough, you can sometimes see this black nice separation from bone to the from bone here to the meniscus, and then sometimes you can see this teardrop like flap that's just hanging over the edge of the medial tibial plateau. So we always need to look out for those. Then the second thing that I wanted to talk about are these friction syndromes. Well, mainly the patellar tendon lateral femoral condyle friction syndrome, because this is again also something that occasionally gets missed by people. So always look here in every case, especially if you have someone with anterior knee pain. So they can be quite subtle, and also don't forget to look on the axials, because you can often also see them here at this location between patellar tendon and the lateral femoral condyle, where we should have nice and smooth fat tissue like we see down here. So always look out for those. And whilst you are at it, also make sure to not miss any other form of fat bed impingement. So we can sometimes see impingement and irritation or inflammation of the prefemoral fat bed here, especially at the tip here, or even like post-contusion changes there if that was a direct blow to the knee. And the same goes for the quadriceps fat bed, or also called suprapatellar fat bed here. Typically, a little bit of increased signal can be seen in many people, so you always have to have a correlation here. In the classical textbook cases, you would then also see additional bulging and fibrotic change here to make this a suprapatellar fat bed impingement case. But in this case, this is within normal limits, so I wouldn't even describe anything there. Okay, so this was the trial of this platform. I think I'm slowly getting the hang out of it, and I'm sure I'm going to use this more often in the run-up to the MSK Olympics, because I think it's actually a nice tool. And let me just go here, we can go. So we will, in the Olympics I will use a different platform though, but I think it's just good for me to get used to the streaming stuff here. We have a comment by FG about the image quality, which you think is amazing. And let me just go back to the case. Yeah, I think the image quality is good. This is our fast protocol. So this is a 5-minute knee, which I think is quite good. Or maybe it's the 10-minute knee. So I think we've got a 5-minute and a 10-minute knee. But although I think this might actually be the 5-minute knee. On a 3 Tesla GE scanner, I think the knee really is the best study we can do on our MRI scanner in burn. The other joints are less impressive, and with the proper air recon DL, and if we do like a 20-minute scan, it really is amazing, the image quality. But although the image quality is much better than this, I don't think I get any diagnostic improvement. So we just go down with the quality to increase speed, and so we can work with 15-minute slots for knee. So that's basically the idea behind all of this. But yeah, thanks for that. The image quality is really good. I'm also happy. And this is my standard knee protocol. We've got a coronal T1, coronal, I think this is a PD fat set, sagittal PD fat set, sagittal PD without fat set, and an axial PD fat set. So this is the protocol. Some people don't go for the T1. I like the T1, especially for marrow stuff, for subchondral changes. It's and generally just for fat imaging, it's always good to have at least one T1 if you have the time. And I think we do have this still at the moment. Okay, so now that we looked at this, I just want to briefly go back to the Olympics here. There's no need for you to register anymore. We've got more than I think we've got nearly 200 registrations, so we will go on a first come first serve basis. We will notify the successfully registered people again closer to the event, but make sure to also tune in here on Saturday, May 24th, because you can also win prizes during the actual live stream. So that's why I'm trying to get the YouTube live streaming stuff here ready and getting the hang of this program here in the back end. So yeah, mark this in your calendar. You can also just register here and then basically just click here and don't register on the next page. So leave this one out, and then we got the email and we will send you the information for the watching of this event. So let's go back to the Q&A session. So we've got two people here in the Q&A session. So Iman and Gotze, if you want to ask any questions regarding knee MRI, I think this is now your time. You can use chat, you can also use the microphone, and we'll have time for answering a couple of questions. And if you from YouTube want to join the actual session, you can also do that by going to school.com MSKRAT. I think the link is still on the screen somewhere down there. Yeah, you can register there for free. There are a couple of free courses, free videos, lectures, great cases, videos and stuff that you can watch. It's completely free. And then we have discussions here about some topics, some announcements, and you can see there's some stuff that's being discussed here in this community. There are 1,800 people and 6 or so are currently online here. Okay, so let's see if we got any questions. Yes, so Gotze is saying, yes, thanks for the great lecture. You're welcome, thanks for attending. If you have any questions, just let me know. I'm happy to answer. We still have a few minutes left, so I wanna... Oh, hi Carlos.
Hello?
Hello, I can hear you. Welcome.
Okay.
How are you doing?
Fine, thank you. And you?
Good. Do you have any questions for knee MRI for the purpose of this stream?
Yeah, not really.
Okay.
Nothing specific.
Okay.
Yeah.
Okay, great. Yeah, so then I do one other thing. Since we have some time, I want to go to the fellowship and maybe we can pick a knee case here. We can see there was one posted here by Dilesh. I haven't seen this, so this was just 2 hours ago. He posted this case. So let's solve this case together because it's anyways the knee session or the knee Q&A now. Okay, so this is the case for, you can see we are using Collective Minds. This is another great platform that I frequently use for the teaching here. This is a case that Dilesh uploaded here, and the question is 52-year-old male, chronic pain, reported posterior, or the question is reported as posterior root attachment tear, and the arthroscopy showed intact root attachment. What criteria do you use to characterize root attachment tear? So I think that's a very interesting case from the description. So this is presumably the preoperative MRI where the posterior root tear was diagnosed. We don't know which side, so we'll find out. And then the arthroscopy was negative, so very interesting. Okay. Yeah, so let's have a look. We can start on the coronal, and we start again with the meniscus on the medial side. You should be able to see that. I just need to make sure. Carlos, I'm going to mute you because I hear some very, very subtle background noises, if you don't mind. Okay. So yes, and let me just pull the chat out of the way so we have more space. Okay, so middle meniscus here is okay. There's a little bit of extrusion, but it's probably not enough to actually really call. So 3 millimeter has been suggested, maybe 2.5. Yeah, so maybe mild extrusion. I think it's a bit more than what we would expect, still to be normal. When we go to the posterior medial corner, we see some degeneration of the meniscus. We want to verify this on the next slide. And when we go here, I mean, the root is torn. I would agree with the MRI here. So we have a look on the other planes here too, but this is not the normal appearance of a posterior root. We can pretty much always see a nice root attachment down here, so it would go down here as a quite a nice black structure. Sometimes, depending on the plane and the orientation, we have to go through one or two slices, but typically we see the posterior root of the medial meniscus quite nicely. Okay, so let's go to the sagittal and do the same thing for the medial meniscus. I'm just focusing on the actual question here in this particular case. We see the posterior root is fine, transverse ligament blending in, and then we follow over here. We see some of these horizontal things are just the vessels that are entering the meniscus. We can also verify, let me just double check here, or not double check, but make this bigger. We can see here, these are just the vessels that are coming in here. So this is not a horizontal tear, this is just the vessels that are going in here. We still have some degeneration of the meniscus, but remember the patient is like 52-year-old, so it's kind of like to be expected. Now when we go from the posterior horn, again we see some central signal increase. Again, this is the vessel, but the signal here around this is still a bit too much, so we can say there is some intrinsic signal or intrinsic meniscus substance degeneration. And when it comes then here, we start to see some irregularities. Certainly there is fraying here on the under surface. We start to see more high signal here inside the substance, and on the next slice from here to here, we see fragments of meniscus here, and we see kind of like a complex tear with some debris or frayed substance in this gap. And then on this image, we don't really see much going down. Well, there is still some this maturated substance. I think that's a good term in this case, this mushy gray stuff here, which might connect at least partially parts of the meniscus with the root here, but it's at least a high-grade tear nevertheless. Even like I would probably prospectively call it a complete root tear. And if we want to give a location of the root tear, we can measure from the insertion. So somewhere maybe 9 to 10 millimeters from its insertion here. That's what I would describe in this particular case. So I would have said also, I agree with Dilesh, that I would have called this a complex tear. We also see these chronic changes, bone marrow edema, cystic changes here. So there's something that's going on here for quite some time. So the question now is, why is the arthroscopy negative? We can see this was the 25th of February. Maybe they did not go ultimately directly to arthroscopy. Maybe there was some intermediate healing in a way. So we don't know really what happened at the time. Let me see if they put in some information. No, it's just chronic pain. Yeah, so based on MRI, we just have to call this a posterior root tear. There's no way around this to make this a normal root. And we can just have a look at another random knee here. I think this is also from Dilesh, and maybe he has the same scanner. So ideally, we are not being tricked by any funny technical things when we are comparing now this with the previous case. I just need basically these two here, so we can actually compare. So when we go now here, anterior root, body, and posterior root, you can see this normal black root touching down here. This is too far posterior. This is exactly the image, and this is how it's supposed to look like. And in the previous case, when we compare this side by side, let me just try to make this happen. So, and this one is this image, yeah. So you can see this is just the difference between these two cases where we have a normal root here, and then this one is kind of like completely torn, macerated. We don't see anything connecting these two bits here. So let's also look at the radial, because I also like the radial quite a bit for posterior root tears. Here, this is where the tear goes through, and this is maybe where one of these fibers might still be intact, also therefore maybe limiting the amount of extrusion that we can see. But again, this is not a normal appearance. And when we go here, we can see it's quite a nice black structure. So part of this will be the root. The slice thickness doesn't really allow us to give us a nice view on this. Let me go back to actually this case and show you the posterior root here on the middle side. So we can I make this go away? No, we need to make this big. And this is now very small. So is it bigger now? Okay. So we can also see here, we had this tear here, but the posterior root itself, it's quite black. Maybe there's a bit of fraying, but that's it. So we can see nice and black. And if we go back here to this case, where was it? No, it was on the other, this one. So make this big, coronal. Yeah, root tear, definitely root tear. So there's no question about that. Yeah, MRI shows root tear. No, this is the wrong case. Sorry. I want to make sure I'm not answering the wrong case. Yes, I agree. I agree. MRI shows posterior root tear, medial meniscus, and mild extrusion. If surgery is normal, either intermediate healing, mediate healing, surgeon loop. Okay, so yeah, maybe he didn't look properly, or there was some fibrotic tissue that looked a little bit intact, but with the probe I would assume that they should identify this as a tear, unless there is some form of intermediate healing. Now this is the wrong one. This is the dealer's case. Okay, yeah, this is a very interesting case, by the way. Okay, so then I have a comment by Yisma Fos. Hi Chris, it is difficult to manage the platform through the mobile phone and watch the stream at the same time. Do you mean, did you watch the stream also on the phone, or did you use the phone for the platform and you watch the stream on a laptop or on a computer? But I can understand that if you only have the phone, it is going to be a bit challenging to see. Okay, so what we can do, let me just go back to the platform. So if you can all go back to the platform here again, I see 10 people are logged in. Now what I want to try, I want to follow mode. So if I do this, technically I should take over your screen, and you should see what I see with my mouse, or at least you should see the scrolling and stuff like that. So when I do this, you should be able to see how I change the sequences, and you don't have to do anything. So even if you're on the platform, it should look like a stream. Let me just double check on my laptop, because I'm new to this platform. Yes, you can also see my mouse, so I think that's nice. So I think that's it's a good tip. Thanks, Mahfouz, for the comment. So good to know that I can use this follow mode to actually take over your screen, so you don't have to follow the stream and the app. So I think that's good. And if you I think you can just scroll over. No, can you not? Well, if I don't do anything, you can still do whatever you want, but as once I start doing this, then it kind of like takes over. Okay, that's good. Good to know. Yes, thanks. Then we have another Tapas comments. Should use 2 devices at a time for smooth running. What do you mean? Like you want to use 2 devices, or I should be using 2 devices? And then we have another question here from the actual live call by Anisha. Is there any entity called ACL sprain, and when to call it? Yes, so ACL, as any other ligament, can have sprains. The problem with ACL sprains is I think it's quite tricky to diagnose. It requires like some form of trauma, but it's not big enough to actually have a proper pivot shift injury. And in English, some people use the term chronic sprain. Chronic sprains would be a ligament that's just a bit degenerated and maybe some fraying with some mildly increased signal. Not like this, I think I would require more, but there are different sensitivities how people go about the ACL. And another thing that people also use is laxity. So some people might describe this as a bit lax. As we can see, it's not quite straight. We can see there is also, well, if you want to be very sensitive, you can argue maybe there is a bit of a anterior tibial translation and give some laxity here. But so ACL sprains, when do I give ACL sprains? First of all, I only give this if it's an acute trauma, and if I see some periligamentous edema in the pericruciate fat pad here around the ACL, but the actual 2 bundles are intact. So I hardly ever, I don't give it a lot. Like it's very rare for me to give it, because the most tears are then partial tears of maybe the posterolateral bundle, or then the classical full thickness tears. Yeah, so that's for the ACL sprains. Very difficult diagnosis, and I think needs a lot of experience and with your own scanner to realize that the ACL is abnormal and not just degenerated. The term chronic sprain doesn't fit my German vocabulary. I don't think we can translate something like a chronic sprain from English to German. That's why I just typically say ACL degenerated in this older patient without trauma. Anisha has a second question. What is the difference between patellar maltracking, patellofemoral friction, and patellofemoral instability? So basically, patella maltracking is when the patella doesn't really, during knee flexion, go. Let me just use collective minds for this because it's a bit better. So if we have the patella gliding here onto the trochlea, and if you bend the knee and the patella goes like places where it shouldn't go, then it's a maltracking issue. This can lead to early osteoarthritis. It's kind of like associated with instability, right? So we as radiologists, we don't really see the unstable portion. We only see the risk factors for it and the damage that it makes. But patella maltracking is more like this umbrella term when we have any issues that impede the movement of the patella during knee flexions in relation to the femur, and this could be through trochlear dysplasia, this could be from patella alta, and so on and so on. So when we have patella alta, then also the patella sits more higher, and the higher it is, the less quickly it falls into the groove and is more likely to just wobble around a little bit and is a bit unstable. And the friction syndrome or patellofemoral friction syndrome, I would not really use patellofemoral friction as a term. It's either a patellar tendon lateral femoral condyle friction syndrome or supralateral Hoffa impingement, or then we have some suprapatellar fat bed impingement. I think there's something else here, but we have either an impingement here or we have impingement there, but it's not really patellofemoral impingement. This is more like either osteoarthritis, instability, or maltracking, as I discussed, or then we have these impingements which occur in the fat around it, not really in the bone, at this level at least. And so yeah, I think that's for that question. Let me just see the chat. Tapas, we should, or you should, the user should use 2 devices. Well, I don't think it's necessary. I think for this platform, I think if you follow the stream, and when I say, okay, now let's go to this presentation, then I can take over and you should be following me anyways. Yeah, but let's see if so what happens if I go back to the slide and I don't have this follow mode on and I want to go to the next slide? It still takes you over. I think this is only for this area. So once I have the follow mode on, it becomes the live stream in a way. The only thing you don't see when you're in here is the chat and the other bits and my face, but you don't need to see my face. Okay, so, but yeah, if you have 2 devices, or that's good. If you have a large screen, you can basically also just basically separate it and have it on one half and on the other half if you're on a workstation. On a tablet, it might be more difficult. So we have another question by Ayats. My next question concerned the appropriate clinical indications for utilizing contrast in knee MRI examinations. Yeah, that's interesting because knee MRI don't really often need contrast. We do most of our knees without contrast unless we are suspecting a tumor or the clinician suspects a tumor. That's the obvious indication, if like something like PVNS, or even if you see a mass like finding somewhere on a non-contrast study, then I would recommend additional sequences with contrast just to get the full picture if we are suspecting a vital mass which is enhancing, just to better to help us with differential diagnosis. And if any other indications, something like, for example, a inflammatory case from a rheumatologist when they are specifically are wondering about synovitis, then you could argue that's probably an idea to give contrast. But to be honest, if you have a fusion and you do, let me just go back here to this case here. If you have a fusion and you window this accordingly, then typically we see the synovitis also in a patient where we don't have IV contrast. So I would say over 90% of knee MRIs we can do without any contrast. If in doubt, I would do without, and you can still get it done after, like in a second go, if you really want to know. Okay, so I think that's probably the the thing. Then we have another question from chat. FG asks, okay, you were comparing the scan that I showed you with your hospital's 1.5 Tesla. Yeah, but I mean, I agree 1.5 Tesla is then less, and some hospitals don't have great image quality, but truth be told, the worse the image quality, the easier it becomes and the faster you can read, because many of these details that we see on 3 Tesla, especially on these very high, very nice images, are not clinically relevant. Like we start to see like small bands and little flaps and stuff, like not these flap that I just showed you, but like small stuff, like I don't know, small little things and stripes where we don't really know what to make out of it. So if you have this more easier, compact, low resolution images, things become just much easier to read, given that there might be some limitations for smaller stuff, but not things that I would assume alter the clinical procedure or the decision making for the orthopedic surgeon. Okay, so where is the chat? Now I lost the Google Meet call, did I? No, here it is. Okay, so then we have another question here from the Google Meet. Variants of bucket handle tear, hemi-bucket handle tear, any resources for that, radial tear, long. Yeah, so the best resource here, Anisha, is the radiology assistant. Let me just go there. assistant.nl. I just type it in chat so you have it. They have, I think, the best overview for these kind of like things, special cases here. They have this flipped meniscus, bucket handle tears, and all these other bits and pieces. So this is a very easy to read, and also with scrollable images. I really like this. They have done a great job in describing these things, and also with some nice illustrations. You can see here the bucket handle, and then the flipped meniscus, and all of these things. Everything is here explained. So here with the big fragment anteriorly, basically flipped anteriorly as the flipped meniscus, and then here compared to that, the classical bucket handle tear. I think the only variant missing here would be a ring-shaped meniscus, which is super rare. In case you wondered, ring-shaped meniscus. I think it's just a very rare variant. Not sure if this is available here. Well, if it's not available, you can always use Google Images to go beyond the paywalls. So you can see this is basically an anatomic variant where they show a ring-shaped lateral meniscus, basically like a discoid meniscus with a hole in the middle. Yeah, they don't. This is a very, very rare variant. Okay. So, and Tapas is asking what's the pathology in the previous case you opened where there's a lot of suprapatellar edema. Okay. Let's see, not this one. I think this was from the fellowship. Now what am I doing? This one's cool here. This was Stiles. Okay. I think this was the case 2 hours ago, posted on the virtual MSK fellowship. I haven't had time to look at this case yet. So let's see, what are the information? 8-month history of pain, no trauma, and there is a mass with synovitis, and the question is PVNS malignancy, with a radiograph as well. So we can see there's some swelling, but we don't see any calcifications. It doesn't look very gouty. Was it a female, 34-year-old female, maybe also not the primary candidate for a gout. So let's go here. We can see on the this is a PD fat set, this low signal mass here in the suprapatellar fat pad, also going a little bit into the, maybe there's some fatty components here. Let's see what else we got. It's quite bright. It has contact to the quadriceps tendon. It's still a little bit heterogeneous and low signal on the T2 fat set. Let's see what else we got. It kind of like goes into the tendon. I think that's why my first initial thought was maybe gout, but I don't think that's the clinical picture. We don't see marked, this is a T1 No, this is pre-contrast. Okay, that makes sense. So this is still pre-contrast, and this is T2. Some darker components here, and we see then on the post-contrast quite extensive enhancement here. And also this is now the synovitis that goes along with it. So basically the description by Dilesh is great. It's perfectly described. So it comes down now to the differential diagnosis here. This is again a post-contrast study here with this mesh-like thing, and then this is just a subtraction. What we don't see is a gradient sequence. We don't see localizers, because I would like to see if, like a T2 star or something, to see if we have any susceptibility artifacts, especially because of these lower signals here. I think PVNS would be in my differential at this point. I wouldn't rule out gout, even if we don't see any erosion. So one way to look at, or one way location to look at, is the popliteus tendon, where we sometimes see gout deposits and erosions. We don't see anything wrong there, but it's low enough for me on a T2 to consider something like gout. What else is low signal on T2? PVNS, gout, amyloid, some other form of synovial fibroma, or nodular synovitis, something along that line. So it will be one of those here, but I think the first differential for me, and also basically the statistically, is most likely a PVNS, given the low signal stuff that we can also see here. So maybe add a T2 star, but I don't think it's going to change much. So maybe they can also straight do a biopsy here, arthroscopy, or however they want to biopsy. Maybe even ultrasound would be easy to do a biopsy here, but maybe they want to do this from the joint inside. Yeah, I'll have to think about this a little bit more, but it would just be like a first quick guess. Well, not guess, but differential. Then we have Kesmat, who's asking, how do you differentiate a ring-shaped meniscus from a bucket handle meniscal tear? So the ring-shaped meniscus, I'm gonna pop this paper here in the chat. Can I chat on YouTube? Yes. So in this paper, first of all, it's super rare, and if you have a trauma, then I would not think about that. I would then more think about a bucket handle tear. And I would also say, like, when we go to the image, the margins of the ring-shaped meniscus should be smooth. Like, you should have nice triangles on both sides. So you can see, I'm not sure here. This is probably two separate cases, but we can see that there's a nice triangle here. There's a nice triangle here, and I'm not sure like how. Although I don't remember, I read the study a long time ago, whether they actually had arthroscopic correlation. Maybe we find out from the text here. They say also it's challenging, and there are reports of negative arthroscopies for suspected bucket handle tears. Well, this might also be that arthroscopy is negative because either the bucket handle tear, flipped back, or I don't know. But yeah, it's challenging, and let's see what they say here, or if they say anything in the abstract. But they had a case with a bilateral ring-shaped meniscus, which obviously is a bit strange for a bucket handle. Various imaging feature that distinguish it. Yeah, its shape, contour, and signal, and also I think history and so on would also play a role here. And yeah, so if you manage to get this article from your university or something, but these are the images they show. You can see it doesn't really strike us as a tear. It's just like a centrally no meniscus and then two triangles which are nice and black, and we don't see any abnormalities. And especially if there's a lack of trauma, I think that would be an idea to think about it. We need to be careful not to fall for these intermeniscal oblique ligaments here, which can be on both sides, connecting the crossing over roots. So typically you only have either or, so you don't normally have both. That's very rare. But I've seen a few cases where we have this connection with the oblique menisco-meniscal ligaments, and then we need to make sure that what we see on these MRIs are actually not pieces of other things that, due to partial volume, give us the appearance of a ring-shaped meniscus. So we need to scrutinize these quite well before we come up with this differential. So because it's super rare. Here, this is another illustration, like they show it, triangle here. Okay, so let me see if if you got any other questions, but actually it's nearly time for me to go to the other session. Okay, guys, I want to close this call here. Thanks very much for tuning in. I hope you learned a few things. I learned quite a bit about streaming and having a live call at the same time, including also using RepMat for any funny things here. And I will try to do this more often, and I will also make sure to announce this more earlier now that I'm getting a little bit the hang out of it. So thank you very much for tuning in. If you have any questions, go over to School. You can just go there. The link is still in the description here. You can register for free. You get free lectures and stuff here. We can continue the discussion about anything here and so on. All right. See you next time. Bye-bye.